Hi, I'm Payman Sanati, and I'm a craniofacial surgery fellow at the University of Washington in Seattle Children's Hospital. And I'm here with Dr. Henny Kreshanti, who is the Director of Plastic, Reconstructive, and Aesthetic Surgery Residency Program at the Faculty of Medicine, Universitas Indonesia in Jakarta. Thank you for joining us today, Dr. Kreshanti.
Thank you, Dr. Sanati.
Our discussion today will be about primary and secondary management of facial trauma, and we wanted to hear a little bit about your experience in taking care of your patients in Indonesia. Dr. Krishanti, we're honored for you to join us today. And to start, can you tell us a little bit about some of the largest paradigm shifts that you've noticed in your career as you take care of patients with facial trauma?
So to answer your question, our patients are mostly, since I work in a university hospital, so many of our patients are covered by the national insurance coverage. So some of them may not have or did not pay the insurance regularly. So we often encountered cases in the emergency room that cannot be admitted to the hospital immediately due to the insurance coverage. So it poses a problem for us because afterwards we will see them in the outpatient clinic, and then usually it will take more than 2 weeks for them to get things done with the insurance. So nowadays, we see more neglected fractures, which is more complicated to treat. But we also have the facial fracture that we can do surgery in time within the 2 weeks period. But the patients that we cannot operate in 2 weeks, then it will pose more complicated techniques and approach, and not and often the aesthetical outcome may not be as good as if we operate before 2 weeks time. Maybe that's the paradigm shift that we see in our hospital these days.
When you think about these challenges, are these challenges you think unique also because you're in such a large urban setting in an archipelagic country? You must see patients coming from different islands being transferred to you. That must also play into the delay that you may see sometimes in the care of these patients.
Yeah, our hospital is a national referral hospital. So we also see cases from other parts of Indonesia, from other islands, and usually they have multiple trauma, and they take care of the life-saving surgery first, and then after the patient is stable, usually it is more than 2 weeks, then they will send the patient to us. So yeah, the referral from the other part of Indonesia, usually they come very late, and it will become very complicated cases to do the surgery.
Once you're planning on doing these reconstructive surgeries outside of the acute phase, do you find yourself using a lot of imaging and virtual surgical planning to plan your operations? And has that changed in recent years?
Yeah, imaging is already well established in our hospital, like CT scan. But recently, we have a 3D printer in our division, and we often use them to plan the surgery and to see whether the reduction, it will help with the reduction by having the 3D printed model before the surgery. But this is not quite often that we do. Usually, when the patient came like very late, and the fracture segment is very displaced, then we'll use the 3D printing. But if the patient came like, say, maybe within 1 month or 2 months, so maybe we just see from the CT scan, and we don't do the 3D printing models.
Thinking a little bit about using 3D printed models and being in a training center, I know you're training residents at your institution. Do you find that having the 3D printed models helps you in training your residents and preparing them for surgery? Is that something that you're incorporating into their education?
Yeah, we use 3D printing models more in the tumor reconstruction. For example, like for the prefibula, for the mandibular reconstruction, then we do 3D printing for sure. So before the surgery, we can show the residents what will happen during the surgery, and we can discuss also with the colleagues from the ENT or the oncology department or the oral surgeon about the part that they will remove. And then we can plan the length of the fibula. And usually the resident will take active part in preparing the 3D models and then in cutting the 3D models into the segments that will be removed by the other surgeon, and then planning the fibula for the reconstruction. So yeah, 3D printing models is we use more and more for the education of the residents.
Great. Thinking a little bit about the future and utilizing technology to optimize patient outcomes and to improve trainee education. Where do you think we're headed? I know you have an interest also in augmented reality and virtual reality. Do you find a place for that in facial trauma management, either in the primary stage or in secondary reconstruction?
Yeah, currently we're developing a model for the learning using the virtual surgery, mostly to learn the anatomy, and we can see the layers of the skin and the muscles and where the nerve, the facial nerves maybe. So the residents can do an interactive learning by making an incision virtually and then see the layers below that and identifying the important structures. And then when they do the surgery in the patients, then maybe they will have more confidence in doing that. So yeah, that's we're developing right now. And other things that I find quite useful for the residents to learn is that when we have models, like maybe the simulator for the cleft lip or cleft palate surgery. So when they do the surgery in the models first, that really helps to shorten the learning curve. So they will master the skill in the model, and when they do it on patients, they will have a lot more confidence.
Right. Yeah, it's really exciting to see how new technology is not only improving our education from a trainee perspective, but also enhancing the patient's care on a day-to-day basis, whether shortening the operations or making more precise osteotomies or dissection. So great to hear that you've incorporated all that. I'm excited to learn more about your experiences in the meeting coming up for the ISCFS Congress here in Seattle in September. I hope that we can see you here in person and learn more from you then.
Thank you, Dr. Sanati. I would really try to come to Seattle. It's a really long way from Indonesia, but I will certainly try to come.
We hope we get to see you. We'd be very lucky.
Thank you very much, Dr. Sanati.
Thank you.